In this piece of the lecture, we are going to look at some of the pharmacological and surgical options for overweight and obesity, or at least some characteristics of some of those. First of all, when we think about possibly using medication and/or surgery for the treatment of obesity, it's important to remember the treatment selection criteria. So essentially, pharmacology and surgery are or pharmacotherapy and surgery are really reserved for people where their overweight or their obesity is posing a higher health risk. Because of course, when we look at using medications and doing surgery, there are risks with those treatment options. So it's really important that the potential benefits of the treatment outweigh the risks or side effects of treatment. So essentially, if someone's in that overweight category of 25 to 27, and if they're in the lower end of that, really diet, physical activity, and behavior modification is what we want to target. If they're in that 27 to 29.9 range, certainly we also want to do diet, physical activity, and behavior modification, but they may be appropriate for pharmacotherapy, again, if they have comorbidities, meaning if they have health conditions that weight is contributing to, such as type 2 diabetes, hypertension, cardiovascular disease, and the like. When we get to the BMI above 30, so in that obese category, again, diet, physical activity, and behavior modification are going to be the cornerstone of treatment at all levels of obesity. But once we get to that BMI of 30, the person may be appropriate for medication if they are interested in that type of therapeutic option. For surgery, typically if the BMI is less than 40, between 30 and 40, we would only consider surgery, or surgery would only be considered if they had significant comorbidities. And if their body mass index is above 30, even without comorbidities, surgery can be an option. So just important to keep these criteria in mind and be familiar with these criteria, so as you're talking to patients you can help educate them on what some of their options might be. It may or may not be your role to recommend a particular treatment option, but certainly it's helpful to be able to let them know what some of the options might be if they want to look into that further, talk about it with their physician further, etc. So when we think about medications, again, may be appropriate for patients with a BMI above 30 in general, or even above 27 if they do have those comorbidities that may be improved with weight loss. So diet, exercise, and behavior modification are certainly still important. So we can't just do the medication and that'll take care of any sort of diet and lifestyle issues. We have to really combine both of them. Typically with medications, the results are only seen while the medication is being taken. So for the most part, and again, this is general, every medication, you have to look individually at the studies and the outcomes with it, but typically when the patient goes off the medication, the weight tends to come back, or certainly not continue to lose, but often come back. So that's really a consideration in terms of whether the medication is seen as a long-term solution. Now, on the other hand, sometimes that it does help people sort of jumpstart their weight loss, which can help from a psychological perspective. Kind of getting that initial weight loss can be difficult to make those changes, so sometimes that medication can be a tool to kind of get them over the hump. Not everyone will respond to medication. So some people it works and some people it doesn't. And for the most part, I think at this point, it's a bit of a trial and error, although I think as things move on, we can sometimes see more accurately which patients it is more likely to work for and which it's maybe not. So I have a different spot in the learning unit this week for specific types of medications. I'm going to direct you to a website for the current list of approved medications for weight loss. But as you look at that, I want you to be thinking about some of the mechanisms of action. So typically for the weight loss medications that are available, it either reduces the appetite and/or increases satiety, so makes the person feel full more easily, or it blocks the absorption of some type of nutrient. So if it's reducing appetite or increasing satiety, usually the target of the medication is in the brain. So that's because that's where our appetite and satiety centers. That's where it, registers to us that we're full or that we're hungry. And if it's blocking the absorption of some nutrient, that target, of course, is going to be the gut or the GI tract, because that's where we absorb nutrients. So it's helpful to think about that with medications and be familiar with the mechanisms of action, because it also suggests what some of the potential side effects might be. So for example, if we're targeting the gut and blocking nutrient absorption, we may also be not allowing other nutrients to be absorbed, which could increase the risk of nutritional deficiencies. So important to think about the mechanism of action so you can think about what the other potential nutrition-related consequences could be. Another clearly more aggressive measure for weight loss is surgery. So surgery might be an appropriate option for patients either with a BMI above 40 or a BMI above 35 if they have severe obesity-related comorbidities. So again, type 2 diabetes, cardiovascular disease, hypertension, things like that that are very severe and really could have benefit from weight loss. It's also obviously important that the patient is in what's considered an acceptable operative risk, so that the risk of the surgery doesn't, again, outweigh the potential benefit that the surgery might provide. It's also recommended that the patient have documented failure of non-surgical weight loss approaches. So essentially what that means is that there's documentation that they have tried other things that are less risky for weight loss, just to make sure that we're using this, not using this too quickly, since surgery does have significant risks associated with it. It is a very major surgery, so it's just important not to do it unless another more conservative approach hasn't worked. It's important that the patient is psychologically stable with realistic expectations about what the surgery can and can't do for them. The surgery definitely is not a magic bullet. It is a tool that it can be very helpful in people losing weight, but there still are a lot of changes that the patient has to make. And it sort of forces those changes, which can help to an extent, but also can be very difficult. So it's really important that the psychological aspect of going through this type of a surgery is evaluated and the patient is realistic about what to expect following surgery. The patient really needs to be well informed, motivated to make those changes, because otherwise if they don't make the changes, there's more risks in terms of nutritional deficiencies or weight regain or those types of things. The social supports is really important. Patients do better when they have supportive social systems, whether that be spouse or family, friends, their social environment, work environment, those types of things. So important to evaluate what sorts of supports they have, and if they don't have that type of support, how to help them get linked in with places that might provide them that support. It's important that the patient does not have an uncontrolled psychotic or depressive disorder and don't have active alcohol or substance abuse. These can be very significant issues that make the risk of surgery much higher. So those are some of the criteria for a patient to go through bariatric surgery. So there's a number of surgeries out there. There are 4 key ones that I am going to have you watch a brief video and look at the description of those. But in general, surgeries, bariatric surgeries or weight loss surgeries fall into 2 categories: malabsorptive procedures or restrictive procedures, or a procedure that combines both of these elements. So essentially a malabsorptive procedure is one that causes nutrients not to be absorbed well, and thereby decreasing the calories that are absorbed and causing weight loss. So that's one element. With a malabsorptive surgery, because nutrients aren't being absorbed as well, that's going to have a higher risk of nutritional deficiencies, and the issue of supplementation becomes very important with those types of procedures. The other category would be restrictive procedures, where those shrink, and a part of the stomach is where those are done. So shrink down the capacity of the stomach, so it restricts how much food can be taken in. So in that type of a surgery, there's not as much risk of nutritional deficiency because there isn't the malabsorption. However, the quantity of food is still restricted, and so as such, the food needs to be high nutritional quality if the person wants to get in adequate nutrients, and typically supplementation is recommended there as well, but it's not as high of a risk of nutritional deficiencies because there's not the malabsorption there. Again, there are surgeries also, for example, Roux-en-Y gastric bypass, which is very common, that both of these elements are combined. So it's important to know when you're working with patients who are looking at weight loss surgery or bariatric surgery, what type of procedure it is, because that drives what your nutrition intervention is going to be. So again, 4 common procedures are listed here. Roux-en-Y gastric bypass is, at this point, I think still the most common, although some are becoming more common. Laparoscopic adjustable gastric banding, or the lap band, is another procedure. Sleeve gastrectomy and biliopancreatic diversion with a duodenal switch. The last one is the most rarely done because it has the highest risks with it. It's generally only done when it's very severe obesity with when there's a lot of weight loss needed, because the risks are very high, because a large portion of the intestine is bypassed with that. I will link in the learning unit a link with some videos that describe how these surgeries are done. Again, I want you to be familiar with that because it's important to have an idea of physiologically and anatomically what's changing when the surgery is done, because that's going to drive what needs to be done nutritionally for that patient. So with these procedures, when we talk about expected weight loss, that's generally expressed as a percent of excess body weight. So how you think about that is excess body weight is the weight that is above what we would be considered a healthy body weight, so, or a quote unquote ideal body weight. So for example, if we calculate a person's ideal body weight as 150 pounds and that person weighs 250 pounds, they have 100 pounds of excess body weight. So that's what these percentages relate to. So for gastric banding, we would expect on average, again, results vary, but on average about a 47% weight loss. So for that example I just gave, where someone has 100 pounds of excess body weight loss, they would expect to lose about 47 pounds. So going back to what that really means, so say about 50, just to round it off, someone's ideal body weight is 150 pounds. They weigh 250 pounds. If they're expecting to lose 50 pounds, that puts them at 200 pounds. Many patients, that's not what they would expect. They would think they're going to get down to their ideal body weight, which in that example is 150 pounds. So it's really important that patients know what to expect in terms of weight loss so they don't have unrealistic expectations. Gastric bypass, or the Roux-en-Y gastric bypass, estimated weight loss is about 62%, again, of excess body weight. Biliopancreatic diversion, as I just mentioned before, has the highest percentage weight loss, about 70%, but also has very significant health risks associated with it, so is not commonly used. So that overall average, looking at about 60% of excess body weight loss. So important to be familiar with at least that ballpark, sort of on average around that 60%, I think is a good number to remember, because again, it helps to be able to talk to patients about realistic expectations for weight loss following surgery. When we look at diet following surgery, there's a lot of very specifics, and when you provide patient education, patients should be educated prior to surgery on what their diet will look like following surgery. And there's some very specific guidelines. For example, the Academy of Nutrition and Dietetics Nutrition Care Manual gives nice information on this intervention, the diet that someone needs following surgery. I'm just going to give some general guidelines here. And this is looking at long-term following surgery as opposed to right initially out of surgery. There are also some additional recommendations. Again, the Nutrition Care Manual is a good resource for that. So looking at how the diet progresses following surgery. But for long-term, the patient can expect to need to follow a low-fat diet, particularly with malabsorptive surgeries. That fat tends to not be absorbed very well and often will be quite uncomfortable if they eat too much fat. Of course, also the high fat can contribute to excess calories, which can not allow them to lose the weight that they're wanting to lose. Typically, they are going to need a low sugar diet. Excess sugar will quickly move through the GI tract and will tend to cause dumping syndrome or diarrhea, so important to follow a low sugar diet. often, not always, but very commonly, patients won't tolerate lactose well following surgery, particularly again with those malabsorptive surgeries, because the portion of the small intestine that is bypassed is where a lot of these nutrients are absorbed. And so it's not going to be absorbed as well, not going to be digested as well, broken down as well. And so it ends up in a lower part of the gastrointestinal tract intact, like the lactose, for example, ends up down there not broken down. And so that causes fluid to move in and can cause diarrhea and discomfort. Patients are going to need to eat small portions. Of course, their stomach size is going to be smaller, and so it's important to have those small portions, or it can be very uncomfortable. And if they eat larger portions continually over time, it can also stretch that new stomach pouch out. Frequent eating is important because they need to eat such small portions, so they're going to have to eat more frequently to get the nutrients in that they need. It's good to separate food and liquid because two reasons really. One is that it can make the person feel too full to eat and drink at the same time. For some people, it can really cause dumping. It sort of liquefies the food and causes it to move through too quickly. And then it's recommended for patients to limit or even omit liquid calories. So those liquid calories are really anything that's liquidy and has calories. So that would be juice, soda, milkshakes, any of those types of things, even if it's considered, kind of healthier like juice. And the reason for that is a lot of these surgeries work by making that small, for example, Roux-en-Y gastric bypass has that small stomach pouch and has a very small opening from the stomach pouch down into the intestine. So that makes food not go through too quickly and the person feels full quickly. Well, if it's liquid calories, so for example, say a milkshake, and that might not be tolerated because of the lactose anyway, but just for example on that, it could easily go through that small opening. So the small opening really isn't going to do its job because the liquid calories still moves through easily. So it's very easy for a person to overeat and not have the weight loss they want if they're consuming a lot of liquid calories. Now, initially, right after surgery, they probably only will be able to consume liquid calories because that's probably the only thing that will stay down. But this, again, is looking at more long-term. And carbonated beverages typically are very uncomfortable, but that bubbling in the pouch is not good. So recommending that they stay away from carbonated beverages. I have listed here several nutrients that are most at risk of deficiency following surgery. Again, the highest risk for these is following a malabsorptive surgery, but there still is risk following restrictive procedures because of the small amount of food being eaten following surgery. So vitamin B12, vitamin D, calcium, iron, and protein are commonly supplemented following surgery. And again, in the Nutrition Care Manual, you can find specific quantities for recommendations on supplementing these nutrients. So kind of in summary, medication, pharmacotherapy, or surgical treatment are options for patients with more severe obesity, and particularly if they have health conditions that the excess weight is really aggravating. But it's important that patients look at, or that the whole health of the patient is being looked at to determine whether the risk or potential risk of either medication or surgery isn't outweighed by the potential benefit. So that's one piece. And then it's also important to educate the patient on realistic expectations for weight loss, any special diet that's going to need to be followed along with the medication and or surgery, and any supplementation needs. So that's really where your role comes in, is providing that education and helping support that patient in making those changes.